Hey everybody. All right, today or this lecture, we're going to discuss some pediatric illnesses, specifically hematology, oncology, and a couple of different cardiovascular pediatric disorders or illnesses. So let's start off with heme-onc, and then we'll go right into cardiovascular, kind of like we did with the respiratory GI. So in order to understand the to be able to treat these diseases in these children, we need to understand the pathophys. And this is one where it's really difficult to kind of wrap your brain around the pathophys when it comes to hematology, because it is so intricate. So you really do need to have an understanding of a basic understanding of the pathophys of the hematological system in order to be able to understand disease process and pathophys. So knowing what hematopoiesis is, right, which is the process through which the bone marrow produces those red blood cells or produces blood cells as well as platelets, whereas erythropoiesis is the production of red blood cells with erythropoietin and iron. Okay, so you've got your hematopoiesis and your erythropoiesis, right? Know those terms. We know that red blood cells increase a patient's hemoglobin and oxygen capacity, which is why when we see some deficits in the red blood cells, we see the oxygenation impairments. The average lifespan of a red blood cell is 120 days, after which they're destroyed in the spleen and the liver through a process called hemolysis, right? Heme disorders occurs when disruptions occur within these processes itself. So like I said, you really kind of have to have a good understanding of the pathophys, because our hematological disorders occurs from the disruption in these processes that should normally take place. Also, you want to understand the red blood cells first form as erythroblasts and then mature through normoblast and reticulocyte stages to mature non-nucleated erythrocytes. So when we take a look at the reticulocyte count, an elevated reticulocyte count, also known as immature red blood cells, of more than 1% of the total count, indicate that rapid production of new red blood cells is occurring. So that's going to be kind of a red flag for us to kind of figure out when we see all those immature red blood cells, the reticulocyte counts increasing of more than 1% of the total count. We know that the body's trying to put out these new red blood cells. Just a couple little facts. Hematological disorders are often called blood dyscrasias. And they occur when components of the blood are formed incorrectly or either increase or decrease in the amount beyond the normal ranges. So you guys know me, I'm always talking about the range, right? We want to be right in the middle. You got too much of something, it's bad. You got too little of something, it's bad. The same when it comes to the blood, when it's formed either incorrectly or either an increase or a decrease in the amount beyond those normal ranges. All right, the coagulation, the steps in the coagulation system, this is actually really important for us to be able to know. And you do want to have a good, not a very intricate understanding of it, but you do need to have a basic knowledge of the different stages within this blood coagulation. So, the clotting cascade, it's a complex series of 4 events, also known as stages, right? Stages 1, stages 2, 3, and 4, which include a combination of blood and tissue released from the plasma, which the plasma is our intrinsic pathway, and also from the injured tissue, which is our extrinsic pathway. Okay, so the clotting cascade, it's a complex of series or events, specifically 4, right? 4 stages, which include the combination of blood and tissue that's released from the plasma, which is intrinsic, and from the injured tissue, which is that extrinsic pathway. The coagulation factors involved are not in order of action, but rather the order in which the factors were discovered, which is kind of interesting here. See how we've got coagulation factors involved 8, and then we've got 9, 10, 11. They're not in order of action, but rather the order in which they were discovered. So when a vessel is injured, vasoconstriction occurs, right? That's kind of the body's defense mechanism. Vasoconstriction occurs in the area proximal to the injury, thus narrowing the vessel lumen and reducing the amount of blood that can flow to that injured area. That's the way our body compensates. Platelets then begin to adhere to that damaged vessel site and to one another, forming a platelet plug and initiating the first stage of clotting. In the second stage, factors from either the intrinsic or the extrinsic system combine with platelet phospholipids to form concrete thromboplastin. In the third stage, thromboplastin then is going to converts prothrombin, which is our factor 2, to thrombin if ionized calcium is present, okay? The production of the prothrombin and factors 7, 9, and 10 all depend on the presence of that wonderful drug, vitamin K, right? This is all starting to make sense now when we think of newborns. When the newborns come out, we give them vitamin K. So the production of prothrombin and factors 7, 9, and 10 all depend on the presence of that vitamin K. This stage will be incomplete. Therefore, if levels of any factors 8 through 12, vitamin K or calcium are deficient, this stage will be incomplete, okay? You won't be able to progress to the fourth stage, which in the fourth stage, thrombin converts fibrinogen, which is our factor 1, to the fibrin, right? And then in this last stage, the fibrin strands form a mesh, incorporating red blood cells, white blood cells, platelets, to kind of form a protective permanent seal at the site of the injury. And then our factor 8, which is the fibrin stabilizing factor, then acts to make the fibrin clot insoluble and then permanent, okay? So to prevent too much coagulation after the seal is complete, plasminogen is then converted back to plasmin, which is a fibrinolysin, near the injury to kind of halt the clotting sequence and puts it to a stop. All right, now let's move into some common hematological disorders. I know that there's a lot of them. These are the most common ones that you're going to come across, and definitely going to want to know for your NCLEX, because these are your common hematological pediatric disorders. So anemia. Anemia is not a new concept. We covered it in Nursing 3 when it came to adults. Not very much different in terms of pediatrics, right? So you know the basic understanding of anemia. It can be caused by multiple factors. It can be blood loss, acute infection, inadequate nutrition, right? A diet inadequate or a deficit in iron, folic acid, as well as vitamin B12. But we want to take a look at the different types of red blood cells when we're talking about anemia. There's different types of anemia. You've got your normochromic, hypochromic, and the macrocytic, okay? So let's talk about the different types of hemolytic anemias. The normochromic is exactly what it says. It's their normal color, right? Normochromic, which is normal color. Normocytic is normal cell size. These types of anemias, normochromic or normocytic anemias, they occur because of the impaired production of erythrocytosis as seen with maybe hemorrhage. Okay, simply too few for effective oxygenation to occur in the body, which can be seen with hemorrhage, as well as maybe an acute infection that can cause that. Renal disease, we learned that renal disease can cause that, or certain different types of neoplastic diseases. Okay, these might cause a normochromic normocytic, which means these red blood cells are normal in color, normal in size, but there's just simply too few of them. which results in the impaired production of the erythrocytes, simply too few for effective oxygenation. Hypochromic, hypo, less than, right? So we're going to think of the color when we come to terms of, or talk about this term. Hypochromic means that they're pale in color. So when the hemoglobin production is inadequate, the erythrocytes become pale and small in size. Now remember, we said size was normocytic, so these actually become what we call microcytic. So they're hypochromic, pale in color, and then they become small, microcytic. So different types of anemias that are hypochromic are your iron deficiency anemias and your chronic infection type anemias. And then we've got our macrocytic, also known as megaloblastic anemias. This is where the red blood cells appear larger in size, but these cells are actually immature erythrocytes, often seen with our nutritional deficiencies, so folic acid, as well as pernicious or vitamin B12 anemia. So they actually appear large in size, but they are in fact considered immature erythrocytes. Hemolytic anemias. This is where the number of erythrocytes are low because of increased destruction. So some common disorders that we see that cause the hemolytic anemias that's caused by low erythrocytes because of destruction within the body is congenital, right? Congenital spherocytosis, which is a genetic congenital disorder that can kind of attack the erythrocytes. Glucose 6-phosphate dehydrogenase deficiency. Say that 5 times fast. Sickle cell anemia, right? Which is, we know that's an autosomal recessive inherited disorder that's carried on the B chain of the hemoglobin. And we know that with the sickle cell, the cells become elongated and kind of sickle shaped. Which I want you to know, sickle cell, obviously, that can cause a sickle cell crisis, which is the sudden severe onset of sickling, which then causes a vaso-occlusive crisis. So we're going to want to know the term. The sudden severe onset of the sickling causes in patients what we call a vaso-occlusive crisis. Okay? And this is most often caused by dehydration. And we know that from last week's lecture, what is one of the most common causes of dehydration? GI illness, right? So if you got a kid with sickle cell disease that comes in with a GI illness, probably going to have a sickle cell crisis on your hands. We're going to want to make sure we're adequately rehydrating them. Also, those with respiratory infections because of that impaired oxygen exchange. Okay, so sickle cell crisis most often caused by either dehydration as associated with a GI illness or some kind of a respiratory infection, so like upper respiratory. So how we want to treat sickle cell: pain relief, hydration, and oxygenation. Those 3 things, okay? We want to make sure that we're treating their pain. Pain relief is going to be priority. Rehydrate them, put on that supplementive O2, which is going to help with the oxygenation, okay? Some disorders of blood coagulation. ITP. ITP is a common one. Idiopathic thrombocytopenia purpura, as well as the Henoch-Schönlein syndrome, as well as disseminated vascular coagulation. Okay, so ITP, this is one that I definitely want you to know. ITP, it results in a decrease in the number of circulating platelets in the presence of megakaryocytes, which megakaryocytes are precursors to platelets. Okay, so they're what's made prior to the developing platelet. So it results in a decrease in the number of our fully grown platelets circulating, but also within the presence of the megakaryocytes. So these kind of, if you think of it, immature platelets, but they're the precursors to platelets. So the cause is thought to be autoimmune. The body's kind of destroying its own platelets, right? On assessment, a classical finding is the infants have petechiae, the little petechiae, and large ecchymotic areas. Okay, so you're going to see large ecchymotic areas kind of scattered, little petechiae that's often seen, I'm pointing to my nose, but really it's throughout the body, as well as thrombocytopenia as seen on their CBC. So when you take a look at their CBC, they're going to have a low level of platelets, okay? Heme syndrome, I can never say that. It's also called an anaphylactoid purpura. This is caused by an increased vessel permeability, which leads to bleeding in the small vessels. And it occurs most frequently in kids between 2 and 8 years of age. So I know I said the ITP, we usually see that with infants, and this one's going to be seen a little bit in the older generation. All right, as well as with this, the assessment, it reveals a distinctive purpural rash that's seen on the legs and the buttocks. All right, so I like this slide. And once again, it's plucked right from your Pilotary, box 44-2. Nursing care, planning using assessment. So looking at the child with a hematological disorder. So when, within the history with your intake, the chief concern brought in with these kids are going to be fatigue, easy bruising, and complaints of epistaxis, right? Those kind of recurrent epistaxis. Fatigue is a big one, right? As well as easy bruising. Really different than when the kids, the toddlers start to move, we get worried about the bruising because they're constantly falling. This is actually bruising on all parts of the body that is caused not by impaction. So looking at the past medical history, you want to take a look. These kids generally tend to be low birth weight or excessive amount of blood loss at birth, right? That's why we always take a look at the EBL when they're postpartum. A lot of blood loss at birth can kind of cause these babies to have hematological disorders in the future. Also, a lack of vitamin K administration at birth. We know that it's state mandated according to the American Academy of Pediatrics, but that doesn't mean everybody's going to get vitamin K injections. So that lack of vitamin K administration at birth can predispose them to having these hematological disorders down the road in the pediatric population if they didn't already suffer an intracranial bleed as a neonate. Looking at a nutritional history, these kids generally tend to be what we call picky eaters, or they may have the presence of pica, where they're eating non-food-like items. They also like their milk intake, so they've got an increased milk intake with these kids. Looking at your family history, you want to look for any kind of genetic or family history of blood disorders within the family itself. All right. Therapeutic techniques for a child with a hematological disorder. Some of the therapy, the ways we diagnose it and treat it is going to be a blood marrow aspiration with a biopsy. We're going to look at blood transfusion, and then also hematopoietic stem cell transplantation, and then possibly a splenectomy. All right, so nursing process, looking at the nursing process. We already talked about assessment. We'll talk a little bit more about diagnoses after. Outcome and planning. Remember, when helping parents plan the outcomes, you need to be certain that they're realistic for both the child and the family. We're always talking about our outcomes for the plan of care and planning. And we always talk about them being smart outcomes. Yeah, that's great. But we also want to make sure that we're incorporating the parents as well as the families and making sure that they're realistic for both the child as well as family needs. All right. Children with these disorders are often prescribed corticosteroids. Therefore, heavy education is going to be involved regarding these meds and their side effects. We want to make sure that we are referring families to organizations for community support. Looking at making sure that they're well aware of the interventions that's going to be taking place, tons of blood specimens, lots and lots of blood draws, possibly lots of blood transfusions, making sure that we're using our EMLA before any finger or venipunctures. All right, and then outcome evaluation, we're going to need to change the plan of care as needed. We're going to need to be able to change it as needed. All right, so I know I kind of already I gave you a basic overview of the therapeutic techniques for these blood disorders or disorders of the red blood cells. So what do we want to do for the normochromic normocytic anemias? So if it's an acute blood loss anemia, what do we want to do? We want to control the bleeding, right? So we want to start by controlling the bleeding, applying pressure wherever the bleeding is coming from, lie them flat, keep them warm, get some IV fluids on board. So get an IV fluid with them and get them ready for a type and cross for a transfusion. If it's an anemia of an acute infection, then we're going to need to know what is that infection. We want to treat that underlying infection. So we're not going to be able to, we're going to want to treat the anemia, kind of counteract it with treating the underlying condition from the acute infection. All right, so knowing what the organism is, what the pathologic organism is, and treating that. Hypochromic anemias, the iron deficiency anemia, right? So we want prevention with this. Prevention is kind of key. So preventing it in infants through breastfeeding, and if not breastfeeding, that's why we do iron fortified formula, which then proceeds to iron fortified cereal for their first foods. So prevention is really kind of key for the development of, to prevent the development of iron deficiency anemia. All right. But with this, we want to treat the underlying cause in older children. So if they're older, treat the underlying cause with an iron compound to kind of replace those iron stores, followed by a diet. You want to change it to one that's rich in iron as well as vitamin C. And then your chronic infection anemia, administration of the iron is going to have little effect on this until the infection is controlled. So like I said, you want to make sure that we're controlling the infection, this chronic infection, with the right resistant antibiotics and anti-infectives. Hemolytic anemias, we kind of already talked about sickle cell. When they're in a sickle cell crisis, remember the pain relief, adequate hydration, and oxygenation. So controlling their pain, get the IV fluids on board as well as the O2, supplemental O2. Hydroxyurea may be prescribed as well. If none of the previous measures appears to be effective, then they may need to be a candidate for a transfusion. Okay? And then also, if it's not manageable and it progresses more severe within each year, then we're going to want to look at possibly a hematopoietic stem cell transplant, which would be a permanent solution to this disorder, kind of last resort. All right, therapeutic treatment for the more disorders. So purpuras, the ITP and the Heme syndrome. So the ITP, idiopathic thrombocytopenic purpura, how we're going to treat this with the little babies and the little infants is we're going to give them oral prednisone, or in Rh positive children, anti-D immunoglobulin. Okay, so children with central nervous system bleeding may require a splenectomy. So really they may resort to a splenectomy if they're starting to have some brain bleeds or central nervous system bleeding because of this disorder. All right, so we want to treat them with oral prednisone or possibly in the Rh positive children, the anti-D immunoglobulin. So get them some IgD. If the child experiences joint pain from the bleeding, we want to give them Tylenol, okay, acetaminophen, rather than the salicylates or ibuprofen, right, because those have the bleeding tendencies, being a prostaglandin inhibitor. If the joint pain is caused by bleeding, we don't want to worsen the bleeding. So we want to make sure that we're using the appropriate pain relief with these kids, and that would be the acetaminophen, okay? We want to avoid the salicylates and avoid the ibuprofen. ITP runs a limited course, about 1 to 3 month course. If the ITP develops chronically, then we may put them on some immunosuppressive drugs that may be attempted to kind of halt the process. All right, so with Heme syndrome, similar thing. We're going to put them on corticosteroids, oral corticosteroid therapy, specifically the prednisone, and allow the disease to run its course about 4 to 6 weeks. But with this one, a few children may develop chronic nephritis as a complication with this. So within the 4 to 6 weeks, we want to make sure that we're monitoring their renal function because of the possibility of the chronic nephritis that can develop during it, as well as chronically down the road. So it would be something that you'd want to monitor for. All right, hemophilia, common blood coagulation disorder. It's commonly a deficiency of the factor VIII. Remember, we talked about all the factors in the clotting cascade. Hemophilia it's a deficiency of that factor VIII, which is the substance that's produced in the liver that assists with the thromboplastin formation in our blood coagulation. So with this, the clotting factors are present, but they're in a diminished capacity. The defective factor is unable to do its job in the clotting cascade. So what happens is that whole cascade is then halted, and the fibrin clot is then unable to form, leading to what we see in the kids, uncontrolled bleeding when an injury occurs. Okay, so both hemophilia A and B are inherited as X-linked recessive traits, which really affects males. All right, females are carriers, but they don't have the disease. Okay, so it's inherited as an X-linked recessive trait, which affects the males. Okay, so on assessment, what we're going to see with these kids, obviously a history of bleeding, history of nosebleeds or that epistaxis, as well as bruising. We're also going to see on assessment the heme arthrosis into the joint cavities, specifically the knees, the elbows, and the ankles. You're going to see some swelling and pain in the joint cavities. A hematoma with pain, swelling, as well as limited motion. So looking at limited motion within an extremities or a joint. And you may see spontaneous hematuria. So you may see some blood in the urine as well if you're collecting a specimen. So diagnostic testing with this, what we're going to look at is the PTT, the partial thromboplastin time, or the PTT. What we're going to find with it, because remember we said that clotting cascade is halted, this is going to be prolonged. So they're going to have a prolonged PTT indicating that ineffective clotting factors, except 7, is going to be prolonged. So remember, our reference range for the activated PTT is about 25 to 35 seconds. We're going to see it a lot longer than that. We're going to see that PTT or the APTT to be prolonged there. You're also going to see a low level of the factor 7 or 9 anticoagulant if you do some blood draws with that. Often, you're not going to see this bleeding in the first year of life until the child starts to walk and fall. So if it goes on throughout that first year of life, one thing that we do actually see where this can be helpful within the diagnosis is when we're doing circumcisions on the kids in the nursery. Those that are really uncontrolled bleeders, we may want to rule out some type of a hemophilia, okay? But if we don't see any bleeding within the first year of life, where we typically will pick this up is when the child starts to walk around and they have accidents, right? They're learning to walk and then they fall and they start to bleed within these accidents. So one of the first common injuries is within the oral mucosal bleeding, okay? Usually like seen in the mouth, like I have the picture here. So nursing interventions with this, we're going to want to administer the factor VIII concentrate, right, from pooled plasma as prescribed from the physician. So remember, this is a lack of that factor VIII, or a deficiency in the factor VIII. So one of the ways that we can treat it is administering that factor VIII. Also, administration of the DDAVP, which is the 1D amino 8D arginine vasopressin. What this is, it's a synthetic form of a vasopressin to help increase the plasma factor VIII in mild cases. Okay, so DDAVP administration, corticosteroids for the child, especially those with hematuria, hemarthrosis, and synovitis. Okay, we're going to want to put them on some corticosteroids for that swelling. NSAIDs for pain relief, but remember to watch them if they interfere with platelet formation, specifically your aspirins as well as your prostaglandin inhibitors like your Motrins. And then we want to avoid the chronic use of codeine. So watch that a little bit in the older population. I think we're getting a little bit better with prescribing the codeine, but avoid that chronic use of codeine. Supportive care with exercise and physical therapy. Okay, so making sure that we're treating them with some supportive care, some supportive devices, with exercise and or PT. So with this, we really need to emphasize the caregiver education on this. Preventing injury in the environment. This is kind of a red flag, or black box, if you will. A really important piece to take away with the hemophilia is it's a lot of education, okay? A lot of caregiver education on how to deal with this and how to prevent injury in the environment. So making sure that there's supervision, helmet use with the bikes, as well as activity restrictions within means. So we want them to avoid any contact sports, provide soft toothbrushes, maybe do a venipuncture in place of finger sticks to decrease the bleeding. Medical alert tag is very important. So they're going to need to carry around a medical alert tag. And then making sure that we're educating them about the prophylactic treatment by administering the factor 8 replacement, okay? Including self-administration as the child gets older and is capable of it. You also might want to refer them to some national community and national support groups, one known as the National Hemophilia Foundation. And anticipate that there might be some altered family dynamics and how illness can impact that family as well as their financial resources. So this is what I mean when I said that black box or red flag. Safety and effective nursing care, right? Promoting safety. One of our top priorities is going to be your safety, right? Airway bleeding circulation. Airway breathing circulation. This is definitely a circulation issue, which is why it's up there with the prioritization on Maslow's. So a child, I just want you to think about it with the development of independent functioning, right? Because we need to be worrying not only about treating the disease, but with the chronicity of this, making sure that we're hitting growth and development with the kids and that we're kind of supplementing and fostering that growth and development within that child. So you want to keep in mind a child's recreational activities really should include other children for socialization whenever possible. We don't really want to isolate them in, the school and within the community or even in the hospital, right? Alternatives should be fun and worked around building their self-esteem as well as promoting a positive body image. All right. Remember, adolescents focus on egocentrism and have a feeling that nothing will happen to me, right? They're kind of invincible. They're unable to see the consequences of their actions. So you want to keep that in mind when dealing with an adolescent with hemophilia. Encourage their involvement in the care, allowing them as much possible, as much control as possible over aspects of the care while remaining safe. Teach them to make good, safe decisions. Isolating them from school, work, and community really can result in causing a loss of that independent functioning that we're trying very hard for them to succeed in and develop. All right, so some nursing diagnoses. I was going to go back to that. Some nursing diagnoses that would be applicable for the child with hematological disorders. Deficient knowledge, right? Deficient knowledge related to cause of the child's illness or whatever the causative factor is, specifically the new and or chronic illness and the disease management and caring for the child with this disease and disorder. Imbalanced nutrition, right? Less than body requirements is going to be an appropriate and applicable diagnosis. Anxiety and pain, right? Anxiety and pain, not that they're the same, but the child may have some anxiety. They may be fearful, as well as have real, whether it's acute or chronic, pain issues. So we want to keep that in mind. And then take a look at the family coping. They may have some compromised family coping related to the long-term needs, and that's going to be your psychosocially one. So with all of our diseases and disorders that we look at, whether it's within the system itself or conceptually, we always look at our QSIN, right? Quality and safety education for nurses. So what are some patient-centered care activities that we can incorporate into caring for a pediatric client with a hematological disorder. What would be, making sure that we have patient-centered care, that we're conforming that care plan to specify the needs of the patient and not the diagnosis itself, right? Teamwork and collaboration. Who are we going to be working with? Who are we going to be consulting with specifically when dealing with a child with a heme disorder? Yes, we're going to be working with the hematologist's office and the hematologist group, but also think about all the people on the acute care unit that you may need to be consulting with, whether it's PT, OT to kind of incorporate safe activities, or it may be child life specialists to kind of incorporate some fun learning, growing activities. So think about all the people that you're going to be collaborating with outside of the scope within the nurses themselves. Evidence-based practice, making sure that we're staying up to date with current guidelines, current practices, as well as educating parents about what evidence-based practice is. Times have changed since when they were kids, so we want to make sure that we're teaching them what evidence-based practice is. Quality improvement initiatives are always in place, right? We want to prevent errors from occurring, prevent any injuries from occurring, and tracking them when they do happen. And then safety informatics is pretty self-explanatory. All right, the nurse is preparing to teach the mother of a child with thalassemia minor. Which information will help eliminate her deficient knowledge? A, no treatment is indicated for her daughter's disorder. B, her daughter's activity tolerance may be affected. C, a minimal decrease in life expectancy can be expected. And D, a child with this disorder is prone to bleeding. So our correct answer is going to be A, no treatment is indicated for her daughter's disorder, because this is the carrier state of the disorder, not the disorder itself. So it's only going to be, we need to understand the genetic composition with that. No therapy is indicated because this is a carrier state of the disorder. A child who has anemia requires a blood transfusion. Which form of blood product is most often used in children? This is easy, guys. Plasma, washed red blood cells, whole blood, or packed red blood cells. And if anybody answered anything other than D, then I'm going to send you back to nursing 2 with Mrs. Brown. It's packed red blood cells, right? They're the most commonly used in children because it minimizes that excess fluid, avoiding that fluid overload. All right, so now we're going to kind of change courses here. Not really too much changing courses, but because they really kind of go hand in hand. When we talk about caring for a child with a malignancy, we also refer to them as hemonc kids. So, hematological disorders can kind of go hand in hand with the oncological disorders, but we're going to focus on the different types of childhood cancers. The ones that are most popular, the ones that you're going to see more commonly in practice, as well as with your NCLEX. So the terms, definition-wise, the terms malignant and cancerous describe cells that are growing and proliferating kind of in a disorderly manner, in a disorderly, chaotic fashion. In adults, cancer usually occurs in the form of a solid tumor, whereas in children, the most frequent type of cancer is that of immune white blood cell overgrowth or leukemia. Oncological disorders, they're a group of complex diseases with uncontrolled growth and spread of these abnormal cells. Like we said, the abnormal proliferation that's kind of in a chaotic fashion. Treatment's going to vary according to the pathophys of the cancer and the subsequent diagnosis. But most commonly, it's going to include chemo, radiation, surgery, and or bone marrow transplant. All right. Knowing the pathophys of a neoplasm is required in order to understand the pathophys of these diseases, as well as knowing the nursing process, how to treat this, understanding the background of what's going on, the anatomy and physiology. So the pathophys of a neoplasm, it's uncontrolled abnormal cell growth that eventually forms a tumor, as seen in like this picture here. And these tumors can be then classified as either benign or malignant. Metastasis, we all know, is the ability of those cancer cells to invade surrounding tissue and or spread to other areas of the body. So it's metastasizing, it's invading the other areas of the body, it's being carried. Causes of most cancers are unknown. Possible causes are chemical carcinogens, radiation, as well as some certain viruses. We also look at genetics and hereditary conditions with oncogenes. With these, they allow for unregulated genetic activity and tumor growth, commonly seen with Wilms tumor with our kids. Patterns of onset of tumor include the developmental stages of infancy and adolescence. Infancy and early childhood, we usually will see like neuroblastomas or retinoblastomas. Wilms tumor can be seen, which is the tumor of the kidney. It's typically discovered by the caregivers noticing a lump in the baby's abdomen while dressing or bathing a child. I say baby, but it can be an infant, it can be a preschool or toddler. That's usually seen with bathing the child. In adolescence, we typically see Hodgkin's lymphoma, osteosarcoma. So it is a treatable disease with cure as a realistic goal. Okay. So this slide, assessing the child with cancer, assessment typically reveals pain with the neoplasm, directly or indirectly affecting nerve receptors. So we may see, the child experiencing pain or complaining of pain with neoplasms, cachexia with anorexia, weight loss and weakness. So they're going to just have an inability to want to eat. They're going to have no appetite, which can then lead to a cachexic appearance or cachexia, weight loss, and will ultimately lead to the weakness and fatigue. You're going to see some anemia with them due to either chronic bleeding, iron deficiency, and limited red blood cells found in the bone marrow. Infection, you may see infections with them, so you want to make sure that you're doing some infection prevention, right? Because they may have an altered immune system from the side effects of the treatment. So you may see them symptomatic of infections, as well as bruising, right, from uncontrolled bleeding or those decreased platelets. So remember, with the bleeding and the bruising, we want to look for any kind of bleeding out, including in the urine, so the hematuria. Okay, but also the general signs and symptoms is that unexplained fever, the bleeding, bruising, morning headaches, and certain neurological changes, especially with the retinoblastoma and the neuroblastomas, the palpable abdominal mass, like we said, seen with the Wilms tumor, your swollen lymph nodes seen with non-Hodgkin's or Hodgkin's, the bone and joint pain, especially with the osteosarcomas or if it's metastasized, as well as that general overall fatigue. All right, so let's take a look at leukemia and lymphoma, the cancers of the within the blood. The Leukemia and Lymphoma Society, the LLS, these kind of go hand in hand, but they are different. So let's start with the leukemia. Your acute lymphocytic or lymphoblastic leukemia is your ALLs. You'll commonly hear us refer to these as ALLs or AMLs, which is your acute myeloid leukemia. So the ALLs, acute lymphocytic or lymphoblastic leukemia, these account for about 75% of the leukemias and involves lymphoblasts, which are immature lymphocytes. Remember, we talked earlier about the erythroblasts, which were our immature red blood cells. Our lymphoblasts are immature lymphocytes. So the ALL accounts for 75% of leukemias and involves these lymphoblasts. Because of the rapid proliferation of so many immature lymphocytes, the production of red blood cells and platelets declines. The highest incidence of ALL is in children between ages 2 and 6. So what we're going to see on physical assessment with these kids, painless generalized swelling of the lymph nodes is going to be revealed. We're going to do some labs on them, which is going to show an elevated leukocyte count with cells kind of almost being stopped at the blast stage. So remember when you guys learned back in nursing 3, the looking at the stages and the shifts within the cells when we're talking about cancers. These, we're going to see an elevated leukocyte count with the cells being stopped at that blast cell stage. We're then going to do a bone marrow aspiration, which is going to be performed at that iliac crest, which is going to help us to identify the type of white blood cells involved, which is going to help us document the type of leukemia involved. The acute myeloid leukemia, AML, involves overproliferation of granulocytes, specifically the neutrophils, the basophils, and the eosinophils. So you got your neutrophils, basophils, eosinophils, and it shows an overproliferation of these granulocytes. What we're going to see on assessment with these kids is pallor. They're going to be very pale. They may run a low-grade fever, very lethargic. They're going to have a low thrombocyte count, so they're going to have some low platelets. You're going to see some petechiae and typically bleeding within the oral mucosa, especially after performing oral care or when they're eating. Easy bruising on their arms and their legs. They also may complain of abdominal discomfort, so abdominal pain, some vomiting, GI anorexia. They also can have some involved bone or joint pain. With that, you may notice an unsteady gait with these kids. And as well as complaining of headache with painless generalized swelling of the lymph nodes. Okay, and also on labs, it's gonna reveal an elevated leukocyte count, as well as blast cells in the cerebrospinal fluid on spinal tap. Okay, bone marrow aspiration is also going to help identify the types of white blood cells that are involved within this. Lymphomas, these are our malignancies of the lymph system or the reticuloendothelial system. Okay, so with this, we've got our Hodgkin's disease, non-Hodgkin's, and Burkitt's lymphoma. So our Hodgkin's disease on assessment, this is going to reveal usually like a one painless, enlarged, kind of rubbery feeling, movable cervical lymph node. That's followed by enlargement of other nodes, as well as nodes found in the liver, the spleen, and the bone marrow, and the central nervous system. With this, you're going to see anorexia and malaise. So they're going to have poor appetite, generalized fatigue, like that malaise. They may also have some night sweats, so where they wake up in the middle of the night with the sweats. They're going to have an elevated sedimentation rate, so a high ESR. Anemia, we're also going to see some anemia on this. And we're going to want to make sure that we biopsy these lymph nodes in order to diagnose it. And we're going to want to get a chest and a CT of the abdomen, as well as possibly a lymph angiogram. So we really want to take a close look at these lymph nodes to see the lymph that's involved. With non-Hodgkin's lymphoma, usually what we're going to see with these kids is enlarged lymph glands of the neck and the chest, possibly going down in the axillary region, and then also in the abdominal and the inguinal nodes as well. If the mediastinal lymph glands are involved, they may suffer from some respiratory signs and symptoms. So you may see coughing or feeling of a chest tightness, as well as some edema of the face. With these, we also need to make sure that we biopsy the affected lymph nodes and do a bone marrow aspiration as well. Burkitt's lymphoma, what we're going to see with these are enlarged painless lymph nodes of the neck and the abdomen, which typically cause a blockage to a body system. So these can be obstructing to other different systems. And then with our Burkitt's, growth is so rapid that the cell mass may double in size in as little as 24 hours. So this is really a rapid growing type of malignancy that we want to get diagnosed because of its rapid proliferation and the potential for the obstruction. Okay, neoplasms of the brain and the bone. We're going to move it a little bit to switch it to the brain and the bone when it comes to malignancies. The brain tumors are the second most common form of cancer and the most common solid tumor type of tumor, most common solid tumor types of cancer in children. So there's different types of brain tumors. We've got cerebellar astrocytomas and medulloblastomas and what we call glios, or brainstem gliomas. Cerebellar astrocytomas, these are slow-growing, kind of cystic tumors that arise from the glial or the support tissue surrounding neural cells. The medulloblastomas are fast-growing, so kind of opposite. These are fast-growing tumors found most commonly in the cerebellum. The brain cell gliomas, these often cause paralysis of the cranial nerves. So these are where we're really going to see some central nervous system defects, especially those cranial nerves. They can cause paralysis of the fifth, 6th, 7th, 9th, and 10th of the cranial nerves. Your bone tumors, these osteogenic sarcoma and Ewing sarcoma, these are the two most common that you're going to see with the bone tumors. What you're going to see with the osteogenic sarcoma, these kids are your taller than average type kids, and you're going to see they're going to complain of painful, swollen sites, possibly inflamed, feeling warm. They may report a recent trauma to the site, whether it's their shin, their leg, their arm. It's going to feel almost DVT-like, warm, swollen, inflamed. And on labs, you're going to see an elevated serum alkaline phosphatase. So, and also, the AST, you're going to see an elevation in that, and you're going to want to biopsy the site to kind of rule out the osteogenic sarcoma. Your Ewing sarcoma, this is more pain that's intermittent at the site of the bone where the neoplasm is. It starts intermittently and then it becomes constant and severe. So it kind of progresses. And typically with the Ewing sarcoma, we see kind of an onion skin type reaction on the x-ray, which kind of looks like onion peels, which is kind of classic of the Ewing sarcoma. So how we want to diagnose this is bone scan, bone marrow aspiration, biopsy. We're going to want to take a look at the lungs with this, so get a CAT scan of the lungs, and then take a look at the kidneys as well. So we want to maybe do an IVP, an IV pyelogram, or an MRI of the kidneys. Okay, other childhood neoplasms. Let's talk about neuroblastoma, nephroblastoma, and the retinoblastoma. So your neuroblastomas are tumors that arise from the cells of the sympathetic nervous system, so from the SNS. These cells are highly undifferentiated and highly invasive. They occur most frequently in the abdomen, near the adrenal glands or the spinal ganglia. These are the most common abdominal tumor in children, is the neuroblastoma. So what we're going to see with this is a palpable abdominal mass after weight loss, the anorexia, so we're going to have decreased appetite, anorexia, and then that palpable abdominal mass, which is going to be felt more commonly after that weight loss. Excessive sweating, possible excessive sweating because of that sympathetic nervous system involvement, as well as the adrenals, and the flushed face, hypertension, possibly abdominal pain depending on the extent of the tumor, constipation, so they're going to have some GI, decreased GI motility causing constipation, and possibly loss of motor function in the lower extremities. How we want to diagnose this is with an arteriogram. Arteriogram is going to be best to diagnose it. If not, we can get ultrasound, CAT scan, or MRI of the chest, abdomen, pelvis. We also want to get a bone scan and a bone marrow aspiration and biopsy. Nephroblastoma, or Wilms tumor, you guys are going to know it by Wilms tumor, is where you feel that palpable, firm, non-tender abdominal mass seen with kids. Like I said earlier, most typically while bathing. Parents will feel it on them when they're bathing the child or when they're dressing the child. So you feel that palpable, firm, non-tender mass. Possibly hematuria with this. They may have some blood spillage in their urine, low-grade fever, and anemia. So we want to diagnose this with a CAT scan or an ultrasound. And then we also want to take a look at their kidney functions with this. So get a GFR and the BUN assays. Okay, you want to make sure that you know as a nurse that we should not be palpating the Wilms tumor because of the risk for rupture there. So no palpation around that when it's suspected. Okay. Retinoblastoma is of the retina, right? It's a malignant tumor of the retina within the eye. So on this, the pupil is going to appear white, and they can also see some strabismus with this. And how we want to diagnose this is with CAT scan, MRI, and an ultrasound. So it's seen with the ophthalmoscope. Okay, some interesting diagnoses for the pediatric cancers are pain, nutrition, infection, as well as family dynamics. So you want to look at pain related to the neoplastic process in the bone, imbalanced nutrition, less than body requirements related to the disease process or the treatment process, whatever the causative factor is. Risk for infection, definitely with the immunosuppressive agents. Disturbed body image can be a big one, especially with your older kids, as well as compromised family coping related to the disease process, long-term chemo regimen, whichever the causative agent is, you're going to have some possible compromised family coping. Okay, QSIN initiatives for dealing with a child with the oncological disorder. Safe and effective nursing care is really key with these kids. I know it's with everybody, but promoting safety and nursing care priorities for complex pediatric heme-onc patients. We want to make sure that we're putting initiatives in place, that we know what they are, and that we're putting the initiatives in place in order to appropriate care for these patients. So we want to triage these kids as quickly as possible and place them in a treatment room as quickly as possible to get them diagnosed. We want to begin neutropenic precautions, which is that protective isolation, especially for the kids that are undergoing treatment. So neutropenic precautions to help protect them when their immune system is so low as it is. We want to make sure that we're putting them in an appropriate environment and instituting those enhanced precautions. Using strict hand hygiene. This is also going to help to prevent the infection. So you want to maybe dedicate stethoscopes, equipment to that room. Watch what's going in and out, right? Think of all that basic stuff that you guys learned in the cancer lecture, right? No fresh fruits, flowers, anything there that can hurt an already weakened immune system. Initiate cardiopulmonary monitoring, so making sure that we've got them up to the EKG, oxygenation as necessary, obtain and monitor frequent vital signs for trends. Keep an eye on the trends, knowing that hypotension is going to be a sign of sepsis, so we want to really keep an eye on that blood pressure. We want to avoid invasive procedures as much as possible. Access the central lines, right? Using strict aseptic technique, making sure that we're only using the 10 ml syringes to flush the line. So making sure the proper protocol is in place when we're working with the central lines, the safety and infection controls. Making sure that we get the appropriate lab values, right? Get their blood cultures, get a BMP, get a CBC, making sure that we're getting a type and screen, as well as the coagulation, the PT and the PTT. Think of all the things that you're going to see on these kids and what you need to rule out to take a look at the severity or the complexity of the disease progress. Start those antibiotics if they're febrile. Try to get antibiotics on board within 60 minutes of an assessment, and then start to monitor them for any adverse reactions when we are initiating those new antibiotics. And if they're febrile, make sure that we're giving their Tylenol, right? 15 mg per kg every 4 to 6 hours. So standard dose, 15 milligrams per kilogram every 4 to 6 hours while they're febrile. Try to avoid ibuprofen as well as the aspirin to help reduce the risk for platelet dysfunction, or if they have those bleeding tendencies or precautions in place. All right, a 2-year-old boy has a nephroblastoma, also known as the Wilms tumor. Which would the nurse expect his parents to report as the first symptom of this tumor? Blood in the urine, chronic cough, abdominal mass, or oliguria? And we know that the correct answer is C. A Wilms tumor grows on the anterior surface of the kidney, so it's felt as an abdominal mass. 6-year-old child receiving chemo develops stomatitis. The physician prescribes xylocaine to be used to decrease the discomfort associated with this. So what teaching should the nurse provide first to the child? So this is for the mucositis or the stomatitis, which can develop with chemo. I know you guys learned about this in Nursing 3, but I want you to think back. These are our basic pharm questions. So they prescribed xylocaine to help decrease the discomfort. What kind of teaching are we going to provide to the child? A, drink the solution with the favorite beverage. B, use the solution after eating. C, not to swallow the solution. Or D, use the solution after brushing the teeth. The correct answer is C, not to swallow the solution. We want to make sure that we don't swallow that solution. It's just like a rinse and spit or a swish and spit. Swallowing of this lidocaine or xylocaine can cause paralysis of the gag reflex. So young children may be apt to just drink and swallow the solution if they're not taught what is to be done. Okay, so it's imperative that we make sure it doesn't go down into their gag, which can numb it. All right, and for a kid receiving radiation therapy, the nurse bathes an infant receiving radiation therapy and notices that there are ink marks at the site where the radiation will be directed. What nursing action is indicated? We're either going to cleanse the marks with soap and water, remove the ink marks with acetone or alcohol, leave the ink marks alone, or apply lotion to the area to keep the skin moist. The correct answer when we've got markings for radiation on anybody, as well as with pediatrics, is to C, leave the ink marks alone, right? These marks are going to be placed on the kid's skin to be certain the radiation is directed at the same points with each session. So leaving such marks in place is important. We want to make sure that we're not applying lotion. This is contraindicated because it could deflect the radiation. Okay, Kawasaki disease. Kawasaki disease is one of my favorites. Not favorite, I mean, it's not a great thing. My nephew, just a couple years ago, was diagnosed. He was in critical condition, diagnosed with Kawasaki disease. So I kind of take this one to heart because I watched him go through this. And it was very painful. And the reason why is because Kawasaki disease is very impressive. And I don't mean that in a good way. I mean it has a lot of problems associated with this. So it's not very popular. It doesn't happen a lot. You don't see it very commonly, but when you do, it can be lethal. So you need to know the signs and symptoms. So I have here, let me talk to you about what Kawasaki disease is. So it's also known as mucocutaneous lymph node syndrome. So it actually starts with the lymph nodes. So lymph node enlargement, it almost resembles mono. When kids are first diagnosed with Kawasaki, as my nephew was, he was first diagnosed with possibly mono. Okay, they were thinking maybe it's just mono. So because it's also known as a mucocutaneous lymph node syndrome, it's actually the leading cause of acquired heart disease in children in the developed world, such as ours. This is a multi-system disease that affects the cardiovascular system and can lead to coronary artery aneurysm. So that's one of the reasons why I said this is such an impressive disorder. So this childhood polyarteritis nodosa results in acute febrile inflammation of the vasculature and primarily affects children younger than 5 years old with a peak incidence around 2. This disease, it's not contagious or congenital, but it's thought to be caused by an infective organism that's usually seen seasonally and in certain geographic locations, with a higher incidence in late winter and early spring. So typical to that of like an influenza. Mortality in children, the reason why this is so lethal is results from scarring and stenosis of the main coronary artery disease, or MI, due to coronary thrombosis. This disease often mirrors other infectious diseases such as measles and scarlet fever. So if you take a look at here, I see it says assessment box 12.1, and 12.1, box 12.1. It's not from your textbook, but it's literally from the box on the right side of the PowerPoint slide. So one of the reasons why this disease is so impressive is because it's a diagnosis based off of exclusion. So you're literally taking a look at these signs and symptoms and you're excluding them out, which will hone down to Kawasaki disease. So they actually take a look at the criteria here. And I think it's based on Jones criteria. That signs and symptoms that last longer than 5 days include high fever, greater than 101.3, plus a minimum of 4 of the clustered symptoms here, which starts with the bilateral conjunctivitis, painful joints, red lips, strawberry tongue. Okay, so signs and symptoms that last longer than 5 days or more with accompanied fever, and a minimum of 4 of these symptoms is what we can do to rule in Kawasaki. So let me talk about, so I want you to take a look real quick at these symptoms. So you look, it's bilateral conjunctivitis without exudate. So they're going to, it really affects the eyes. Painful joints, almost like that hemarthrosis that we were talking about. Right here, the red lips and the strawberry tongue and the congested oral pharynx. This is kind of classic of Kawasaki disease. They almost call it like cat-like tongue. So whenever you see like somebody that's suspected, like I did with my nephew, when I saw a rash on his face, I said, I want to take a look at his tongue. Does he have a strawberry-like tongue? My mom, when I said that, literally freaked out as what the heck are you talking about? Strawberry tongue is really kind of classic of Kawasaki disease, as the conjunctivitis and the nonspecific rash. So you're going to see nonspecific groin rash, edema and red erythema of the hands and the feet, an increased white blood cell count. This can actually mimic scarlet fever, and diffuse polymorphous rash, and extreme irritability. So, like I said, Kawasaki disease, the diagnosis is through exclusion because it often mimics other diseases like scarlet fever, like mono, toxic shock syndrome, right, because of the hands and the feet, and mycoplasma. So initial lab results will indicate an increased white blood cell count, lymphocytosis and thrombocytosis occur. So you're going to see a high, lymph count, and you're going to see high thrombocytes, which is one of the reasons why they're at risk for MI due to coronary thrombosis. All right, so we're going to want to start them on some blood thinners ASAP, like some aspirin. Also, you're going to see a high fever that is not resolved with antibiotics or antipyretic therapy that may develop. And a life-threatening complication of Kawasaki disease is the development of the coronary artery aneurysm. So what you need to do with these kids are you need to get a baseline echo on them, get an echocardiogram right away, and then you're going to get one again in about 6 to 8 weeks to compare it. And after the onset of the symptoms, to rule out any complications of the coronary artery aneurysm. And then they're also going to have a follow-up echo in 1 year to rule out any scarring or stenosis of the tissue. So complications of this, and the reason why we do that is complications include myocarditis, pericarditis, leaking of the heart valves, pericardial effusion, and CHF. And here's, to me, what's kind of jaw-dropping. MI occurs in 73% of children within the first year of diagnosis. So it's really extremely crucial that not only do you get the disease under control, they're going to be admitted and usually started on IgG. I'll talk about interventions in a minute. But not only that, as it is the importance to follow up with the follow-up care, getting that baseline echo, getting a follow-up echo and also following up with cardiology to track any stenosis or thrombosis because of that high statistic. 73% is an extremely high number of kids that can die from a myocardial infarction within the first year of this diagnosis. So it is really a pretty impressive illness. So some nursing interventions, we want to maintain anti-inflammatory meds such as high-dose salicylate therapy, so some high doses of aspirin, which can also be continued for about 6 to 8 weeks post-hospitalization as an antiplatelet therapy. We're going to want to start them on some IgG, IV gamma globulin, which is given for the first 10 days after the onset of symptoms to help prevent the coronary aneurysms. And you're going to monitor the child's cardiac status closely for signs and symptoms of CHF. So meticulous I's and O's, taking a look at their vital signs, listening to their heart sounds, especially in the valves. This is when it's important to know the aortic, the pulmonic, the mitral, and the tricuspid valves. And unfortunately, after that, nursing care is just aimed at symptom relief. Okay? So for caregiver education, you want to encourage professional intervention in the infant or the child that has a unresolved fever. Okay, if they're still carrying on a fever like my nephew was after doses and doses of NSAIDs and antibiotics because they were ruling out mono, you want to be proactive and encourage intervention. Get them to the hospital. Keep pushing. Get them checked out so that the child will have a positive outcome. Okay, and lastly, rheumatic heart disease. Rheumatic heart disease is a systemic inflammatory disease that occurs in response to the group A beta hemolytic streptococcal infection, such as strep throat, rheumatic fever, or scarlet fever. And it starts in the throat. So when it's left untreated, when they've been diagnosed with strep throat, rheumatic fever, scarlet fever, when it's left untreated or only partially treated, the infection spreads into the bloodstream, and usually 20 days after the onset of the illness. If the infection remains untreated, it can lead to bacterial or fungi clumps that can break off and travel to the lungs, to the brain, to the kidneys, and other organs, which is when you then see rheumatic fever. So once that happens, damage to the heart valve ensues, which is now considered rheumatic heart disease. So antibodies are produced in response to the organism, and lesions develop in the heart and the joints. This disease is thought to be familial. It often occurs in children between 5 and 15 years of age who are generally of a lower socioeconomic situations. And one would think that because they don't get the treatment that they need for, let's say, strep, or they don't finish their course of antibiotics, or they don't have access to it. So it's prevalent in the northeast part of the United States, usually in the winter and the early spring. So assessment-wise, what are we going to see with assessments? Usually we see abdominal pain, nosebleeds, chest pain and heart palpitations, and paroxysmal nocturnal dyspnea, PND. The paroxysmal nocturnal dyspnea is that sudden feeling when you're waking from a sleep. So you're sleeping and you get that sudden feeling that you need to sit or stand up. So waking from a sleep with the need to sit or stand up, that's also considered paroxysmal nocturnal dyspnea. That's often seen with this disease. So some diagnostic tests. I apologize. This is the Jones criteria that I was talking about. I confused it with Kawasaki. So the Jones criteria, which was first established in 1944, and it's continually updated. But with the Jones criteria for diagnostic tests states that there must be 2 of the major criteria present, or 1 of the major criteria present and 2 of the minor present with a streptococcal infection. The major criteria include symptoms such as polyarthritis, carditis, subcutaneous nodules, a non-pruritic ring rash, so a non-itching ring rash on the trunk of the arms, and subcutaneous nodules. Those are the major criteria of symptoms. Minor criteria of symptoms are a history of rheumatic heart disease, an increase in the C-reactive protein, and a fever greater than 38.5 degrees Fahrenheit, and evidence of heart block. So physical assessment, we're going to do blood tests for the presence of exposure to the strep infection. We want to get a cardiac workup, so get an EKG, echocardiogram, and look at a chest x-ray to see if it shows any enlarged heart and CHF per chest x-ray. So you may see some cardiomegaly or myopathies. So nursing interventions, we want to maintain the administration of inflammatory meds and antibiotics. You're going to prepare the child for admission to the hospital and or surgery, and provide detailed education to the family regarding the prevention, the treatment, and the recurrence of symptoms, and what to watch for and when to get help. Okay, so some caregiver information. You want to educate families on the screening of school-age kids for sore throats. Educate families on the need for completing antibiotic regimens or prophylaxis as ordered. Prepare the caregiver for possible hospitalization or heart valve surgery. Encourage regular checkups with their cardiologist. Encourage their immunizations and the annual flu shot. And here is where it's always usually an NCLEX question. Provide education related to the prophylaxis antibiotic therapy needed for dental work. So anytime they go in for dental work, they're probably going to need a prophylaxis antibiotic script, such as like penicillin or something, prophylactically prior to having any dental work done.